Another large percentage is assisted living. So we get a lot of referrals from that. Some from direct doctors, but mostly hospital. There's such a demand for home health, but there's not enough companies at this point to handle the referral volume and also the payer mix. And that's kind of been the challenge for home health. It's not a referral problem. It's really the payer mix problem, and also if you're contracted or you're not, or if the rates are favorable or not. And so what ends up happening is we get probably, because we have like Navi Health and other things, probably hundreds of referrals a day. Those are not there anymore.
You're listening to Home Care Hindsight, the podcast where we talk with home care leaders about the big mistakes they've made and the even bigger lessons they've learned along the way. I'm David Knack, head of sales here at Zengage, and I've built a career on the idea that we learn a whole lot more from our mistakes than from our successes, which is great because I've made a lot of mistakes. I've gotten to know some of the leaders in this industry who've built amazing businesses and are super well respected. So I thought it'd be fun, instead of asking them about the great things they've accomplished, to have them tell the story of one of the biggest mistakes that they've made and how that mistake changed their thinking and the way they run their business. All right, welcome back to another episode of Home Care Hindsight, brought to you by Zengage. This is a kind of unique one, and it's one that I'm really excited about. One of the things that I want to do over the next few weeks is have experts from other verticals in home-based care come on the show and share a little bit about their world and what they have going on a day-to-day basis and how home care agencies fit into the work that they do. So to kick off this series that I think I'm going to just call like 101, so this is Home Health 101. We'll see if that sticks. I'm joined by Stephen Gonzalez, who's CEO of HealthView, home health agency, hospice out in California. And so, Stephen, welcome to the show.
Well, yeah, thank you. It's been good knowing you too. I think I want to say we met right around when you were kind of starting the podcast. I think we were in Nashville or something.
That feels right. Yeah. We talked about it at...
We met in email, but like in person, I remember.
Yes.
Because you're like, I want to get this podcast going. And yeah, so it's cool to have seen it develop.
Well, for people who aren't familiar with you, how would you introduce yourself?
To start, like kind of how you did, CEO of HealthView. So we're a care continuum company. So we do home health, palliative care, hospice care. We do assisted living, also skilled nursing. But primarily my focus is more on post-acute, not the assisted living side. But the thing that was interesting about this topic is actually started my healthcare journey in non-medical home care.
Yeah.
So I do understand like the sales approach on how to market to a home health or hospice or assisted living as a non-medical home care provider and how that fits within the care continuum.
Yeah, that's awesome. One of the things that I think stood out to me about you guys at HealthView, aside from having a really healthy business that's growing and doing all kinds of cool stuff, is from everybody hears about the nursing shortage and all the challenges around retention and turnover and staffing in home health. And one of the things that you guys have done, I think, has really made culture your differentiator. And so talk a little bit about like how you think about recruiting nurses and retaining those nurses and building culture where people are distributed, they're out in the field, and it can be kind of lonely, across the industry.
Yeah, I think, it has to be your differentiator or something has to be your differentiator. It's too competitive, especially in Southern California for nursing across the board and therapists. We take great pride in really focusing our energy on developing a place where people can grow, they feel safe, that kind of thing, and also not feel like a big box company. We have a lot of those in our area, and there's a lot of patients to take care of. So there's a part where, that needs to exist, and we're just a part of that ecosystem. But how we separate ourselves to even compete with a health system that has their own home health or hospice or Kaiser, we really have to make a differentiated experience. And so that's really where we focus on. We just most recently were listed on Fortune 100 best places to work. So we're number 23. Yeah. So I'm wearing my Jordans today to represent our number 23 on the list.
That's good.
But yeah, that's really our primary driver. Like through CMS, everyone has the same kind of service that they have to offer.
Yeah.
The thing that they don't tell you is the nurse delivering that care can be different. And I think if, you invest really in the people, they're going to kind of do that extra thing for the patient. And that's the differentiator for them to make the call back for the second referral or those kind of things.
Yeah. Very much like you take care of your people will take care of the business.
Oh, yeah.
I have plenty of people who listen who have been in home care for a long time. I've got other folks who are just starting out. But let's start at like very foundational stuff of like, what is home health? How do you get patients? What do you do with them? Who are all the stakeholders you interact with? How long do you keep patients? Where do they go after you discharge them? Like, walk us through kind of overall, what is the regular day-to-day of home health like?
Yeah, I mean, home health it's kind of interesting when you own a home health company and you have a hospice company, because they're kind of the two different philosophies. You have really kind of the home health is really therapy, get better.
Yeah.
And then obviously you have hospice of, helping them have a comfortable end of life. So I think for us, it's, when we take care of a home health patient, typically it's to try to get them better, from a injury or something, or some kind of sickness that they just got discharged from the hospital. They need some therapy, so occupational therapy, personal or physical therapy, clinical, so wounds or something like that. I would say it's more advancement, like to get them better. And that's really kind of our focus with the care plan. And some of those cases, being that we have a palliative care company and a hospice company, that getting better part may not be an option anymore. Sure. So that's where some of the patients end up. They can end up in the other parts of the care continuum. And then others, they get discharged back to their normal setting. We'll obviously keep tabs on them, but for the most part, they go back to home or wherever they call home, and they can continue their life.
Yeah. So it sounds like nearly all of your referrals come in through discharges from the hospital?
A large percentage from hospital, but another large percentage is assisted living. So we get a lot of referrals from that. Some from direct doctors, but mostly hospital. There's such a demand for home health, but there's not enough companies at this point to handle the referral volume and also the payer mix. And that's kind of been the challenge for home health. It's not a referral problem. It's really the payer mix problem. And also if you're contracted or you're not, or if the rates are favorable or not. And so what ends up happening is, we get probably, because we have like Navi Health and other things, probably hundreds of referrals a day.
Hundreds of referrals a day.
A day. Yeah, that we can't take from the different hospitals around, because it could be like an insurance conflict. We don't have a contract with that insurance or that type of insurance. Or it could just be like financially, we can't accept the patient because we'll go out of business. It's too expensive of a patient. And so a lot of home healths are not accepting patients because of the payer. So that's where you kind of get into the Medicare Advantage deal of a lot of home healths not accepting patients. So we're one of those. We're a larger straight Medicare agency. So we've been, lucky to have good referral sources that have been able to provide for that. So we have a healthier payer mix. But I would say for the most part, to kind of combat that, we've operationally a lot more than I had when I was coming into the industry to drive efficiencies, like a lot with AI tools and, open AI and all the other different AI apps that we can use, that we do use, to optimize our business, because the margins are not there anymore, especially now with managed care. So I would say it's probably like 50% of our hospital business is in and around the hospital systems. And then we have the rest are home-based or assisted living, some type of home setting.
Sure. So you said a couple of things there that I want to kind of circle back on, which is like, there's this conversation in the home health and the broader, home-based care ecosystem about the difference between Medicare and Medicare Advantage. I think a lot of people probably are familiar with some of those differences, but from your perspective, like, what are the key differences and why is it that Medicare Advantage poses new challenges for home health?
Well, I think it's, they have to be profitable, and they're kind of like the middleman. So they get the sort of capitated rate for a patient, and they have that whole amount, and then they decide what they want to pay. And so the contracts are not always favorable for home health. So they don't typically do home health, but they outsource it to an agency. So they're, especially in our area, we have like Optum and Kaiser. We have a lot of the large, we have Providence, a lot of the large health systems. So they kind of dictate what they want to pay, and they're not really open to negotiating. And so usually financially, it's upside down, because like say a rate is $125 a visit, but your nurse is wanting the majority of that, right? So like the cost, the labor cost is increased at a higher pace than what they're willing to reimburse. And then when you try to every year you try to increase that, they try to decline it, or like not decline it, decrease it. For Medicare, well, that's why we're going to DC next week. For home health, they're saying they want to decrease rates by 6% or a little over. We're getting kind of pinched is there's no rates that are going up. So, but labor costs are going up, right? So therapy costs are going up. Everything's going up. And so there's too thin of a margin for us to take some of these patients, but the Medicare Advantage companies don't want to also bend on what they're paying. And so what ends up happening is you have a low utilization of home health. And so a lot of people end up back in the hospital, which ends up costing everyone, more money. It's one of those. I mean, it just, you have a large company that controls a lot of the patients. And you have then secondary, I think that one of the articles Home Health News just posted, I mean, there's like a few big home health companies that manage almost the whole entire industry. And then there's like a bunch of us regional players or littler companies. So though we don't typically get the favorable rates, this is definitely an arm wrestle, but hopefully there's some changes with that where Medicare Advantage maybe, and not that they're doing anything all wrong. I mean, I think straight Medicare, there are just by itself to manage a whole patient, from every service they need, I mean, is on them, is really overwhelming. And so that's where Medicare Advantage came in to really help coordinate everything. And I think some of it they do well, but our area of business, they've not really made any real adjustments.
Yeah.
So
you mentioned like CMS ratings and that sort of thing. What are the kinds of metrics or quality measures that you're targeting? And how does that interact with reimbursement and likelihood of getting referrals and the health of your business?
Yeah, I think more so now. I mean, I think star ratings will affect payment, but I think the thing that's a little easier these days are the analytics, like the being able to utilize the technologies that are available to us today, like AI, that can crunch and data process at fastest speeds that we've ever seen. Where before we were kind of used to off the shelf BI tools, business intelligence tools, or some kind of thing that you just gave you like a regular report. But a lot of what the hospitals are looking for, say it's readmissions or things like that, a lot of what we do is we'll pull out, like from WellSky is our EMR that we use and very happy with. And so we pull out that data and we run it through some of our external reports that we created on our own. And then we will kind of parlay that into a presentation or something like that to a hospital system, but it's very, very tailored to like their unique need. And I think now we're able to personalize data out of the EMR using these tools, where before maybe you needed like, a few MBA analysts, people or something like that. Like now, I mean, we could do it with our phone. It's better. And I think we're able to tailor it to what the need is. And it could change. I mean, it could be different per system, but a lot of it is hospitalizations is a big one.
Sure.
And rehospitalization. So those are what key, like really key.
Yeah. And this is probably really obvious, but like, what's the reason that hospitalizations, rehospitalizations are such an important metric from a quality rating perspective, but also when you're going to pitch to, a hospital or some other kind of health system?
Well, I think for reimbursement, with like value-based and everything else, they're on the hook. So, I mean, if within, 30 days or so, the patient goes back for the same thing, the reimbursement is affected. And so when they discharge that patient, they don't want, it's not that if the patient needs to go back to the hospital, obviously we want the best care for the patient, but they want that safe discharge to go beyond 30 days out of the hospital, 45 days and 90 and all of it. And so I think because acute care setting is way more expensive, so for the whole overall system, so I think hospitalization in general, I mean, hospitals really should be for very acute sick people. I think everything else we could probably handle at home. And I think it's a lot cheaper. It's way cheaper than a hospital stay. And so you're starting to kind of see that move where I would say even for hospitals, maybe 10 years ago, 5 years, like their main thing was fill the hospital up. And now it's kind of like the opposite, right? I mean, so I think when people were started to be accountable for the overall cost of the patient and it affected their pay, then you started to see health systems becoming more savvy too on what agencies they wanted to use. And so one of the strategies they used, if they didn't own their own a home health, hospice, or home care company, they would build like networks, so preferred networks of who they would refer to and that kind of thing. And then you would have like quarterly meetings on how your performance is. And then based on that, if they decide to keep you in it or not. And so those are things that you have to be able to be ready to present on.
Right. So there's an opportunity to get into one of those preferred networks, to maintain your position in one of those preferred networks and keep the volume of referrals. And I would guess that's a good way for you guys to make sure that you're getting higher quality referrals that you're more likely to be able to take and not be underwater on the reimbursement for.
Yeah. And I think, and then it even goes down even deeper. I mean, understanding if you're going to be underwater or not, so I think that's how we unfortunately have to filter our referrals, because we like the people we work with. We like what we do for a living. So we kind of want to do this for a long time. And so if we keep taking those patients, we're going to be out of business. And that's not, the goal. So there are patients where we do take on a percentage, but it's probably no more than like 10%. I mean, we're really kind of losing on, but that we're doing a patient that, really is having a hard time getting discharged safely and the hospital is getting affected. And so we'll, as a good partner, we would do things like that. But for the most part, unfortunately for home health, it's become that kind of business that you have to look at that, because if you just take all of those referrals and you think that's good, it's growth, and you have, say, 400,000 revenue coming in, but it's costing you 600,000, you really are not growing, right? It's unfortunate, but that's really how we've had to start looking at how we get reimbursed and what partners we could use.
Yeah, makes sense. So just to kind of sum up, like the home health job, the role in the continuum is to get patients better after a hospital discharge or some other kind of, acute event. And the thing your referral partners are going to judge your success on is, did you keep my patients out of the hospital long enough that it didn't impact my reimbursement? And beyond that, did you do good work, and is the patient's outcome good? But at a minimum, did you prevent them from harming our reimbursement and revenue and all that kind of stuff? So let's talk about the home care part of this. How do you see, or what are the challenges that you guys see? Are there gaps in the services that you provide that, like home care, that non-medical home care is set up to fill?
I would say for all of post-acute providers, including home care, the enemy, unless it's purely needed for the benefit of the patient, is the hospital. Home health, in many ways, I mean, it's intermittent care. They're not there for large amounts of time for a long period of time. And it would be cost prohibitive if that was the case, right? Like a RN there for 30 hours a week doesn't make sense, I don't think. And unless it does make sense, if it's a real skilled need, and hospice, kind of the same thing. So for home care, I always feel like it's such a pivotal part of preventing hospitalizations, as long as the home care provider and the actual caregiver are kind of weaved into the care plan per se, because a lot of times obviously they're either a separate company or sometimes they're all the same company. But I think I've seen success where the home care company is really kind of lockstep with the home health provider, or if there's another service, because they're their eyes and ears. I mean, say they're there 20, 30 hours, or even if they're like almost live-in kind of situation where they're there, they have someone there 24/7 to pick up on changes, that could put the patient at risk for going back to the hospital. Because a lot of times, I mean, those things could be triaged through a nurse, either via phone or physically a nurse showing up to prevent that. And a lot of it's just maybe like over anxiety. Like there's certain things that a skilled, nurse can help with, or even a doctor that can call. They're probably the more important parts actually of the care continuum. I just think I see a lot of it being kind of disconnected because it's non-medical. So I think we kind of toss it out like, well, they're not clinical, but I've seen a lot of different companies actually advance in that area to be a lot more kind of clinically driven, where they have maybe like a wellness director or LVN or RN that kind of leads their clinical path. So I would say they probably want to be more to survive, I think, for home care. They're going to have to be looking at a more clinical model, at least to fit in the care continuum with different companies.
Yeah. I think that makes a ton of sense to me that home care's got so much more surface area coverage inside of the home. And so they're much more likely to detect those changes in condition. What are the best ways that you've seen home care providers, whether it's the caregiver, whether it's like the client care coordinator, get out of those silos and make sure that feedback loop is bringing you guys in at the right time?
Yeah, so I see home care as like a distributed assisted living. So I mean, if a home care agency has 150 clients, it'd be like the equivalent to 150 residents. And so I think if they looked at it and ran it a lot similar to like an assisted living with, engagement and other things, and also like reviewing each client on where they're at in terms of like acuity and things like that, I think they probably would have better success. Because assisted livings, I mean, they do really well. I mean, obviously it's one place, so it's like it's easier to market to, I get. But they really have a good handle on partnerships with home health, with hospice, with anything, primary care doctors. So I would say like if they looked at it kind of more like that, to see how assisted livings are, because that's a non-medical, thing. It's very similar. They have caregivers and all of that. It's just, their ratio is different. But I think if they maybe looked at it that way and how to fit in themselves into that, but also like as a package of going to like a home health or even a hospice company, but looking at it as like, hey, I have 150 clients. And a lot of them too, they don't have eligibility because some of it's private pay, or maybe it's on some kind of program. But looking really at like their eligibility, what insurances they have, really understand what a home health is going to want to know. We have to do that too, like on the education part for an assisted living, because a lot of it's private pay. They don't need like the insurance. That's kind of like a thing, right? But a lot of our assisted livings, they know to like check for those things, and we're able to help assist with eligibility and other things, as long as it's a referral, to kind of get an idea if we're able to even take the patient. And so I think a home care company, if I was a home care company and I say I had 150 clients and I did that, and I had, say, 50 of those clients were Medicare, and then the rest were all of these managed care, I would go with something and go to a home health company and say, either a regional one or a larger one, that I have all these clients that could use also home health services, and this is their payer mix. Would you be able to take these? And then vice versa, right? And then from there, can we look at your patient mix to see where a home care provider could fit in? Because too, like for home care, we would have to not just assess if they needed, because I think the majority of people actually do need caregiving services, help, or even like relief for the private, like the actual, like the caregiver, the husband or the wife or whoever, the kid. It's just the affordability piece of it. So like us also determining if the people can afford it. And then if they have other avenues for connections to programs they may qualify for. So say like one's a veteran and like, can they help assist with getting them paid services through whatever that is. And so I think coming in like that, I would say it's really a true partnership and it's equitable and, you know, both parties kind of get their beak wet. That's how I would probably approach it is look at it more from the clinical side and understanding what a home health company is going to need to get that patient on service. And the likelihood is that home health is going to probably work with that home care provider because they just got 150 new patients.
So I've heard a lot of people in the home care world talk about, you know, really tracking your data and, you know, keeping metrics on hospitalizations and all that kind of stuff. I haven't had anybody say to me, home care providers should be keeping track of their clients' payer mix. And that feels like a much simpler thing to just add to an intake form and just say, hey, you know, like, you know, we collect a lot of information about our clients because if they ever need a referral for home health or hospice or any other kind of service, we want to be able to be a helpful part of that continuum, you know, this kind of client-centric picture here. And then that's a really useful piece of data for you guys to know, not just like, do we like this home care provider? Would we maybe like to work with them? But like, is it a business fit even remotely for us to work together?
Yeah. Well, even if the partnership is even possible.
Right.
So it could be, you know, you could be spending, you know, all this time marketing to a home health and you finally, you know, you get the meeting, you're there and they agree, come back to the table and you look at their 150 clients and you're like, darn,
right.
None of these pairs we can take. Yeah. Right. And so I think coming to the table with, hey, this is how many clients we have and this is their insurances and our caregiver and our client care coordinator have a great relationship and, you know, they would love to have a skilled nurse come in and it actually would help the home care agency. But yeah, I would say that there has to be an actual ability to partner. And that's the only way you can. And a lot of people, they have a lot of different managed care coverage. There's not a lot of agencies that may even have the ability to accept those payers. They can maybe start the contract process, but that can take, it's like construction, right? So that contracts take forever. You know, I'm not a big fan of wasting time. So, I mean, I wouldn't want to waste my time of trying to partner with someone that I can't even partner with and know what they have to bring. If they have a large straight Medicare population, any home health would want to partner with them without a doubt would want to. And they could even project vaguely like what that revenue would even look like for them. Because once they come with something and they get that working relationship starts to happen, and then say the home health has, you know, 500-600 patients or 1,000 or whatever it is, then they can say, hey, this is how we assess for home care. And then they have basically potentially that many leads versus knocking on doors. Then there's also a relationship already built. Yeah. And so I would say too, for like, cause we have one home care company that we partner with. It's a smaller company, Synergy Home Care. We like it, cause you know, it's owner owned. It's a great guy. He comes and meets with the team. It feels very connected depending on too, like what kind of market you're going for. So if you're a small market or you're regional or you're national, you have to really see if you can fit within those organizations. I feel like I do the best too when I come to a business meeting with something to give, not necessarily expecting anything right away to gain. Most of the time you gain, you know, like it's just, how am I going to help this person's business? And this is what I have to give. And then typically what happens is, you know, it ends up working out. It's not the most Harvard MBA speak, but it works in real life, you know?
I mean, I think this is a great takeaway for me is like something to give is something that like costs them nothing. It takes like very little extra work. Just make a part of the intake process, gathering that information. And then of all the home care companies that have pitched you, I would guess very few of them have come and said, hey, we took a look at our payer mix and just wanted to share the results and just see if it might be a fit for us to partner together. Like I would guess like that almost never happens to you.
None. Yeah, it's not. Yeah, even the other home care company, they actually came though with referrals. So that was a good, yeah, for hospice and home health. But the assisted livings, I have those types of relationships with the assisted livings. Some we manage, some we don't manage. And we have a lot that we don't manage that we have those relationships with. But we really understand their business on how they're trying to maximize, their business. And so how we come to the table. But because their utilization, I mean, they're like anyone else, right? Like if they don't want a bunch of different providers in their building, it's really difficult to control, especially for survey. They come in or, state comes in. There's just like this hospice company has a binder. This one doesn't. It's just confusing for the staff. And so I think in most companies, including us, like for a home care provider, I wouldn't probably even extend it beyond maybe like 2 partners. Like I would really want to just narrow it because you want to have more control and connection. But the assisted living, that's the kind of relationship we build because increased utilization for them means higher skilled nursing labor that they don't necessarily pay for, right? Medicare is paying for it and managed care is paying for it. And so they have a RN that's there 40 hours a week seeing patients, or they have, like an MP coming in. It's better for them. They don't want hospitalizations, right? Because there's an opportunity for that resident not to come back. And so they know that they're limited beyond just their caregivers on the floor of what the capabilities are. There's more for them to offer.
I think that's a really good takeaway here too, is like what's in it for home care providers to partner with home health is not just additional referrals from home health into home care, but also in the aggregate longer length of stay because they're able to leverage the skilled resources that you have at no additional cost to the patient in many cases because Medicare is covering it. And the result is that you've got people who you've got more expertise around these patients. And I would guess I don't know that this happens every day or you'd want to encourage a whole lot of this, but there's probably a lot of times where you guys might get a call from an assisted living building just asking for some advice on a patient that you guys don't directly manage, but the nurse is able to, because of the relationship and the partnership, able to offer some good kind of advice on here's how I would handle that, even though we might not be the best fit to take care of that individual.
Yeah, that's partnership. When you have a true partnership, there's a lot of that happens and it's very integrated. And I think that's the best for the patient, to be honest. I mean, I think the care coordination piece, and I know we talked a little bit about like technology and all this other stuff, but the one thing that a real bummer, for patients is the care coordination part of it. There's still a very siloed thing. A lot of it too is it is technology problem. I mean, a lot of these EMRs are closed from the hospital the data doesn't really flow. So it's hard to kind of jump from one box to the next box. And that person didn't talk to this person. And a lot of our population, they're older seniors. That's confusing for them, bless their hearts. I mean, they call and they will say, hey, it looks like your insurance changed, because we run eligibility monthly to make sure nothing lapses or whatever. And they're like, oh, well, some gentleman called and said I get it. So there's all that kind of stuff where they get signed up for some kind of managed care thing that they had no idea about. And so there's just a lot of confusion around it. So it's like the care coordination thing, we're all adults and professionals that chose this profession. And if we tie in and do really well in the care coordination, that's our job. Right? To work alongside, if we don't own that other line of business, it's our job to not make the end experience confusing for an older person that's already trying to figure out how to deal with mortality, right? It's just there's so much stuff going on with that. It's so we try our best to find the right partners, even if they're not our own company. And if there's an opportunity for us to get in that business, we might. But I mean, we just really want to have that relationship because once communication's broke, the end experience for the patient and the families that are involved, it's really devastating.
Yeah. Well, as we wrap up here, I want to kind of ask your thoughts on, what's the future for home-based care, what do you look forward to that you're excited about? Is there anything that's kind of looming in the horizon that makes you feel nervous?
I would say personalized medicine. I think with the advancements of technology, might be possible. Early on, I didn't think so. I was kind of like, I don't know if that's going to ever be possible. But I would say looking at the advancements and from week to week, how fast things are moving and how fast information can be processed and personalized, I think that's possible. And I think if we could get there, there's going to be way better outcomes, because I think we band patients in specific kind of groups of you're like this patient, and they kind of get the same thing. And we have, very overworked PCP, primary care and gerontologists, and we don't have enough gerontologists, but I mean, they're overworked to spend enough time with people. And so I think the data too is going to hopefully give them more information about someone to maximize, say, the 15-minute visit or the 20-minute visit. Like, I think we're going to see a lot more advancements in that area where I think will advance people's health. So I would say that those are probably like really exciting. The other thing that's exciting is the actual technology itself. And I think every company is going to have the ability to build their own software by commanding of agents to build their own thing. And I think it was never possible to even kind of really build your own EMR unless you were a big company. But like, I think that would even be possible in the next probably few years, where you could build your own software as your own company, personalized to you. So I think personalized software solutions based around your business model, not just like, I'm a home health company, so I have to use this thing. So I think there's going to be a lot of advancements in that. We are always last post-acute with any technology advancement. So I would say like what we're seeing currently in other industries, I mean, we're probably a few tiers down. For our company, I do have a technology background. So I mean, that is something that we're looking at, and a lot of it we're doing. That's pretty exciting. Like for us to actually be capable of building our own stuff. I mean, so it's pretty cool. I mean, it's a cool time to be alive for sure, to see how much is happening so quickly. I've never seen that. So I was telling my team, actually, I wasn't a fan of anything AI related, but in seeing it work, it's just, it's amazing. I mean, I go back to like when my uncle, when I was like 10, taught me how to build computers, and learning C++ and like being so enamored in that. And then the dial up and seeing the internet, and my eyes just like, that's how it feels right now, where it's like, how is that possible? And so I think, how is that possible? I think anything's possible. So it's like that part of it, I think with technology, like we will have the ability to free up a lot of people's time to focus on patients more, to focus on the actual human things. And I think that was kind of the reason computers were built, was for us to go do life. Those things are the personalization of medicine. And I think the personalization of software that you need specifically to your business need is going to be possible. And I think freeing up people's time so they can go live and do good work and be human and do the human stuff like really well, do the human stuff really well, is what I think is pretty cool.
Yeah, that's what we're excited about too, is letting technology do the stuff, the chores, the laundry of the business, and letting us go, connect with people and play outside. Stephen, thanks so much for coming on today. It was a really good time.
Yeah, thanks, man.
On behalf of the team here at Zengage, thanks for listening to the show. We'll be back next week with another episode, so be sure to subscribe wherever you listen to podcasts, on Spotify or Apple or YouTube. Leave us a rating while you're there. It helps other people find the show. If you have comments on the show, drop me a line, david@zengage.com. Would love to hear from you, chat with you there.